It is now my distinct pleasure to introduce our SGIM president, Dr. Eric Bass. Dr. Bass is a professor of medicine with joint appointments in the Johns Hopkins Schools of Medicine, Nursing, and Public Health. A rabid Duke fan, he tore himself away from Durham after college and med school to complete his residency and master's in public health at the University of Pittsburgh. Dr. Bass is a renowned expert in evidence-based medicine and the assessment of the effectiveness, safety, and costs of medical and surgical management strategies. He has directed the Johns Hopkins Evidence-Based Practice Center and the DECIDE Center. His work has really illustrated this year's meeting theme, Building the Bridges in Generalism, and he was a founding editor-in-chief of the journal dedicated to community-based participatory research called Progress in Community Health Partnerships. He's a talented educator and has directed the Johns Hopkins GIM Fellowship and the medical school's concentration in public health and community service. Finally, Dr. Bass has demonstrated a profound commitment to SGIM and its mission in ways far too numerous to list here, and were recognized in his receipt of the Elnora Rhodes SGIM Service Award in 2007. After he was elected SGIM president, Dr. Bass was described as, quote, a leader who is respected for his research skills and clinical acumen, admired for his accomplishments and mentoring track record, and beloved for his warmth, collegiality, and generosity. Dr. Eric Bass.
Wow. For the second year in a row, the SGIM meeting began on my wedding anniversary. Ironically, of the 12 columns I wrote for the forum this past year, the one that generated the most amusing replies was the one about daring to ask your family for feedback on work-life balance. All right, tell the truth. How many of you dared to ask? I don't see many hands going up. That's okay. If Katie and Jamie were here, they'd tell you I do a better job talking about work-life balance than actually doing it sometimes. 31 years ago, Katie and I met with a minister for premarital counseling. The minister asked us to take a personality survey. After reviewing the results, he said he'd never had a couple who felt so strongly about their views on everything. He warned us we'd have trouble reaching agreement on issues. He was right. Maybe life would be easier if we agreed about everything, but it would be far less interesting. As an organization, SGIM tends to attract and retain members who agree about many healthcare issues. That agreement is fostered by the values we share: excellence in creative and innovative approaches, collegial support and mentorship, partnerships and interdisciplinary collaboration, of course, social responsibility and equity, and diversity. It's easy to work together when we have shared values, and it's easy when we agree. The problem is that we can grow complacent and avoid controversies because it's challenging to work together when we don't agree about how to solve a problem. Furthermore, one area of disagreement can negate many areas of agreement. I see this as a recurring problem in efforts to build and sustain strong bridges between professional societies. One of the themes of my year as president has been to try to build and strengthen our bridges with other organizations. We've made progress in our relationships with the ACP, the Alliance for Academic Internal Medicine, Society of Hospital Medicine, American Academy of Family Physicians, Association of American Medical Colleges, and even the grassroots Primary Care Progress. But it bothers me, for example, that the Primary Care Organizations Consortium does not include two of the organizations that have the greatest numbers of primary care physicians, the ACP and the AAFP. I'm pretty sure the ACP and the AAFP have more issues about which they agree than about which they disagree, but the areas of disagreement have been barriers to working together more effectively. And yes, I know I'm going to hear more from Dobbs Center about that. It doesn't have to be that way. In our efforts to strengthen the bridge between SGIM and the Society of Hospital Medicine, we discovered that SHM has a much less restrictive policy on external funding than we do. Despite that important difference, we've been able to collaborate on running the annual Academic Hospitalist Academy. Indeed, the funding issue creates tension, but SGIM and SHM have continued to work together to offer an educational program valuable to many new hospitalists. Over the years, SGIM has wrestled with a number of controversial issues. Perhaps the first controversy was about separating from the ACP and changing the name of the organization. According to our posted history, we had a difficult year in 1985-86. Membership and meeting attendance were climbing, but the partnership we'd enjoyed with ACP was waning. 2 years later, we officially changed our name from SREPCIM. Anybody remember? The Society for Research and Education in Primary Care Internal Medicine, to SGIM. And we sought an incorporated status separate from ACP. I think most would agree that the change worked out well. One of the biggest controversies within SGIM occurred when I was an ex officio member of the Council 13 years ago. A group of members submitted a proposal to create the Anticoagulation Thromboembolism Research Consortium, supported by a large grant from a pharmaceutical company. Needless to say, the proposal stimulated opposition from many members. The ensuing vigorous debate raised concerns about SGIM's policy on external funding and led to formation of the External Funding Task Force, which I must say was led masterfully by Mike Berry. Ultimately, the task force constructed a comprehensive policy on acceptance and disclosure of external funding for any SGIM activity and established a practical process for implementing the policy. To give you an idea of how difficult it was to establish consensus, the funding policy went through 15 drafts before it was approved by the Council in the summer of 2002. As we know now, the final policy was more conservative than SGIM's previous policy and much more conservative than that of most professional societies. Although it was impossible to get all members to agree, the Council agreed it was important to avoid conflicts of interest that might create a perception of inappropriate decision-making and to avoid excessive dependence on external funding in general or from any single source. The policy has served us well and often is cited with pride by many of our members. Another major controversy arose in 2010 when Arizona decided to pass the Support Our Law Enforcement and Safe Neighborhoods Act, right before we were scheduled to have our annual meeting in Arizona. At that time, the bill known as Arizona SB 1070 was the strictest anti-illegal immigration measure in U.S. history, striking at the heart of SGIM's commitment to diversity, equity, and social responsibility. When outraged members called for SGIM to boycott the meeting, the Council faced the prospect of losing nearly $1 million if we backed out of the meeting contract. I remember vividly how Gary Rosenthal and his council listened carefully during a town hall discussion during which members expressed their concerns passionately. After much angst, the meeting went on in May 2011, but with measures taken to express objections to the law. Indeed, many members who attended the meeting took time to march on the state capitol in protest against the legislation. We didn't seek out that controversy. It happened, and we reacted. Should we wait for the next controversy and react as best we can? Or should we go looking for controversy? Bill Moran's going to kill me for suggesting we do more of the latter. After all, I'll be passing the gavel to him in 2 days. But I believe SGIM is strong enough to be more involved in addressing controversial issues in clinical practice, medical education, and clinical research. Many important problems in our healthcare system are complex and thorny, often with strongly held opposing points of view. Do we really want to limit our voice to the issues on which we all agree? More than once, I've heard a member say that we need more Republicans in SGIM. I realize that's not a popular thing to say to an audience heavily tilted to the liberal side on most policy issues. Even living in the very blue state of Maryland, I've been frustrated by how often our hands are tied when we can't connect with congressmen and senators on the red side. And I shudder to think how little support we'd get on Capitol Hill for issues that matter to us if we ended up aligned with only one party on all issues, and that party had no control in either the House or the Senate. One of the biggest controversies within SGIM occurred when Recently, we've had our toes in the waters of two controversial issues: physician payment reform and gun control. Under Harry Selker's leadership, SGIM created the National Commission on Physician Payment Reform. Of note, the commission was chaired by former SGIM President Steve Schroeder and Bill Frist, the former Republican Majority Leader of the U.S. Senate. The commission made 12 recommendations for reforming physician payment to help constrain costs and optimize care. After the report was issued in March 2013, our Health Policy Committee has been working to get other organizations to endorse the report. Initially, the AAFP balked because they did not have a representative on the commission. But last week I received word that the AAFP has agreed to support the recommendations, which I think can be attributed to the efforts we've made to meet with the AAFP leaders and learn more about their policy priorities. SHM has also agreed to support the recommendations of the Commission, again showing the value of efforts we've made to strengthen our relationship with other professional societies. On the issue of gun control, I signed a letter about a year ago urging the Senate to pass measures intended to curb gun violence. The letter was based on a statement prepared by our Health Policy Committee. We took a risk supporting a position strongly opposed by some members. When two members contacted me to express their concern about SGIM's position, I asked them for permission to share their comments with members in one of my columns. They boldly agreed. I also recommended that we develop a better process for sharing dissenting views when SGIM takes a position on a controversial subject. Perhaps such discussions would help us develop more sophisticated positions, having a better chance of gaining bipartisan support. At the time, I also encouraged people to volunteer to serve on the Health Policy Committee, especially if they feel their perspective is not represented well enough. The biggest controversy that arose this year stemmed from SGIM's participation in the Choosing Wisely campaign that was launched by the ABIM Foundation. The purpose of the Choosing Wisely campaign is to encourage physicians, patients, and other stakeholders to talk about tests and procedures that may be unnecessary. We were asked to create a list of 5 things physicians and patients should question. The list was put together by a work group from our Evidence-Based Medicine Task Force and Clinical Practice Committee and was led by Larry McMahon. The work group selected topics from a nice spectrum of our domain as general internists and they reviewed the available evidence in each area. The group formulated 5 evidence-based recommendations that were approved by the council. Okay, the recommendations are shown here. How many disagree with any of the first 4? Okay. How many disagree with the 5th? Okay. A lot more. Obviously, many members have concerns about the last recommendation. Of course, that was the recommendation that received the most attention, even getting picked up by Consumer Reports, for example. I thought it was important to listen to members' concerns and provide opportunities to share dissenting views with other members. In the February issue of the Forum, we published a letter from the group that objected to the recommendation, along with a response from the Choosing Wisely work group. In the March issue of the Forum, I dedicated my column to the issue. We also initiated a blog discussion using GIM Connect, and we'll be holding a town hall discussion of the issue on Friday at 3:30 p.m. That doesn't include all the phone calls and email messages. This kind of issue reminds me that controversies can be anxiety-provoking and time-consuming. That's why we tend to avoid them. However, I see this controversy as an excellent example of how we can develop a better approach to a problem by listening to different points of view. Initially, I thought it would be possible to reach agreement by just providing a better explanation of the reasoning behind the recommendation. I now understand it may not be possible to get everyone to agree. Some people may disagree on how to interpret the available evidence. Others may disagree about the role of an evidence-based approach when humanistic concerns are not directly addressed by existing evidence. Nevertheless, if we are serious about our commitment to creating value for patients, our new tagline, we need to address the humanistic concerns raised by an evidence-based policy that discourages annual checkups for asymptomatic adults. I hope many of you will attend the town hall session to explore that topic further. To some extent, the Choosing Wisely controversy is just a foretaste of what's yet to come if we're going to tackle the challenge of creating value for patients. This is uncomfortable territory for us. What does value really mean? Some people equate value with cost. Are we willing to talk about cost? When I wrote the column introducing our new tagline, I explained that the idea came from the plenary presentation that Richard Barron gave at last year's national meeting. Dr. Barron highlighted the challenges we face in efforts to improve the quality and efficiency of health care. And he pointed out how general internists are uniquely qualified to be leaders in providing health care of greater value to our patients. The tagline is meant to affirm that the heart of our mission is for patients. Clearly, we value social responsibility and equity for all patients we serve. By introducing the word creating in the tagline, we emphasize that innovation is a core value. Lastly, the tagline places the notion of value squarely in the middle of our mission. Although some people may object to emphasizing value if it's interpreted as focusing only on costs, the word value has many potential meanings in healthcare, and as I said, a good tagline can have more than one meaning. Not surprisingly, some of the feedback on that column was negative. A former SGIM president pointedly asked whether we intended to give more attention to material values than to human values. Clearly, that was not our intention. The definition of value that fits best with our tagline is anything intrinsically valuable or desirable, not just things measured in monetary units. As part of my preparation for this speech, I asked each of SGIM's committee chairs to identify the most important controversial issues that SGIM needs to address. The chair of our Clinical Practice Committee, John Butter, said the following: I hope SGIM will have a voice on the moral quandary that will arise when physicians include cost as a factor in medical decision-making. It's inevitable that physicians writing guidelines and at the bedside will include cost as one of several factors that impact a recommendation. We will need to be transparent about the role that cost has on our clinical recommendation so that we maintain the moral imperative of beneficence and appropriately balance this with the imperative of stewardship of limited resources. I agree with John. It's time for us to have a stronger voice on how costs get incorporated into medical decision-making. Here's what I heard from other leaders of the Clinical Practice Committee. From Janine Engel, I believe that the most pressing topic relates to the interface of the electronic medical record and the delivery and documentation of the care delivered. Current regulations require that the physician do much of the work and document it. This has shifted much of the work to physicians. As team-based care models are evolving, there has not been any evolution in the documentation of care toward the team. We need to be considering what future team-based documentation looks like and how we can prepare for that within the current regulatory environment. To me, Janine's thoughts seem very consistent with Bill's plans to focus on team-based care in the coming year. For my good friend Brent Petty, first, I wonder if SGIM should address the wisdom of pay per performance, given the imperfection of quality measures and their relationship, or not, with actual patient outcomes. Second, I wonder if SGIM should address the propriety of Medicare's 2 midnight benchmark for inpatient designation and the substantial cost shifting from insurer to patient that it creates. My response to Brent is that we have not addressed the problems with Medicare's 2 midnight rule, but it's a good example of an issue that could be addressed in collaboration with SHM and the ACP. Regarding Brent's first point, turns out the Evidence-Based Medicine Task Force recently started a project to do just that, developing a standardized approach to appraising the validity and quality of performance measures relevant to general internists. From Charlene Mitchell, Brent and Janine both have excellent responses. I would second Brent's comments about the 2 midnight rule. From a clinical content perspective, there's always the controversial topic of chronic pain management and the current swing away from use of opiates. It's also a theme that impacts hospitalists and hospitals, as the question, how well was your pain managed, is an important question on hospital consumer surveys. Regarding Charlene's comment, I'd point out that the problem of opioid use and pain management is one of the ACP's major priorities now, and it's an area where we could collaborate more with the ACP. I also solicited comments from the chairs of the Education Committee. Michael Rosenblum said, a major challenge and undertaking has been moving in graduate medical education toward competency-based models of progression through the use of milestones. Many programs in medicine and beyond are struggling to implement the milestones in a meaningful and effective manner. Rena Cranney said, the new ABIM maintenance of certification requirements are a very big deal. There's so much pressure on internists, and these new requirements will have a significant impact on those who have increasing pressure to meet clinical administrative demands. My response to Michael and Rena about the GME issue is that SGIM can collaborate with the AAIM on its internal medicine redesign initiative. And we have 2 members on that project's advisory board, Shobi Sheda and Monica Lipson. We also have an MOC task force led by Eric Green that's well positioned to help guide our approach to ongoing interactions with the ABIM. From the research committee, Joan Nooner offered what I thought was a provocative comment on how AHRQ and PCORI have moved away from investigator-initiated grant funding. She said the narrow focus of the institutes seems much more likely to provide small incremental updates to the status quo in primary care than to fund truly innovative work. On the other hand, given their small budgets, requests for proposals based on the institute's highly focused priorities at least seems more fair to the researchers. After all, the researchers aren't sending in investigator-initiated applications when there's less than a 1% chance of being funded. When I connected with the chair of our Health Policy Committee, Mark Schwartz, I received several suggestions for issues meriting attention. On physician payment reform, Mark asked, do we align with family medicine and advocate for new codes favoring primary care services, or with ACP and broaden the approach to include all evaluation and management codes, thereby favoring all cognitive specialties? On GME, Mark asked, do we take on the hospital community who will rail against efforts to use indirect medical education funding to incentivize GME performance aimed at promoting a generalist workforce? On research funding, Mark posed another question. Should we join others in taking ARC to task as it moves farther away from investigator-initiated grants in response to White House pressure to focus on Affordable Care Act-related contracts? I'm not done yet, Bill. Just in case you didn't have enough challenges for your year as president, I thought it was important to also touch base with the chair of our ethics committee. And Lisa Lehman had great suggestions about ethical issues that SGIM could be addressing. She said the ethics committee has been working on ethical issues involved in the care of undocumented immigrants. We don't have provisions for adequate care of undocumented immigrants in the Affordable Care Act, and given that we have not as a society come to a consensus on immigration reform, health care for undocumented immigrants remains controversial. Lisa also said the committee's recently published a paper on ethical issues in accountable care organizations, and this topic remains important. We're only beginning to see the ethical implications of the reorganization of health care, and many of the issues that were a concern with managed care are likely to resurface. The committee is also working on ethical issues in physicians' use of social media and the issue of professionalism. Genetics is another area with many important issues. As our technology advances, we'll struggle with who should have access to genetic information and who should decide what information should be disclosed to patients, parents, and families. She wanted to say, one significant issue that we continue to avoid is rationing and the cost of care. The Choosing Wisely campaign is a good step forward, but has avoided the elephant in the room, and no one in our society wants to directly address health care rationing, particularly at the end of life. This is one of the most controversial issues in our society. The bottom line is that there's no shortage of important controversial issues. Are we strong enough as an organization to tackle these issues when we know that not everyone will agree on the remedy? We don't have the resources to address all these issues, but I believe the organization is strong enough to provide a more powerful voice on the issues that are most important to us. Within SGIM, we've created channels for communication between members and leaders, and we have people on the council who are truly great at listening to opposing points of view. We share a core set of values, and we have an admirable policy on conflict of interest. In addition, we've invested considerable effort in strengthening our bridges with other organizations. Those relationships will give us opportunities to extend our reach and impact beyond what we could do with just our own resources. We may need to compromise on some issues and agree to disagree on others, but there will be plenty of controversies where we can stand together with organizations such as the ACP, AAFP, and SHM. Let me close by reminding you that the theme of this year's meeting is building the bridges of generalism, partnering to improve health. The program committee, led by Nita and Happy, has done a fabulous job putting together a terrific program centered on this theme. While you're here in San Diego, I urge you to think about the controversies that trouble you and the opportunities we have to address those controversies. Talk with your colleagues and council members about the issues that are most important to you and to your patients. Pay attention to the areas where agreement may not come easily. And be ready to get more involved when you feel passionate about an issue. With your help, SGIM will continue to grow in its capacity to address the controversies that demand more of our attention. Thank you for your attention this morning and for making this year the most rewarding in my career. I'm okay. Thank you. Okay.